Welcome, everyone. My name is Stephen. I am COO, co-founder of Keona Health, and this is the second in a series of talks that we're having on workflows and the importance of workflows inside of patient access and contact centers. With me today is Gina Tabone, nurse and expert in nurse triage and patient access, having spent several decades working with contact centers, starting with the Cleveland Clinic, then as a consultant. Gina, thanks so much for joining us again today.
Thank you, Stephen. It's so good to be with you. And I'm glad that we're able to revisit the topic of workflows or, processes. Essentially, when we're talking about organized contact centers or call centers or communication hubs, whatever the pertinent word is, we are dealing or we tend to put tasks, activities, things to do in three buckets: people, technology, and processes.
Right.
And we have been discussing processes in great depth and their importance and their role when we see that different organizations or practices look to sort of make everything common, what their employees are doing during the course of a phone call or in clinic situations during an office visit. So, again, we're always trying to mimic the work done in person into a virtual setting. So, all of those same tasks that are accomplished when a patient shows up to the office need to somehow translate into a remote encounter. That's very important. And it gives our employees, our agents, our nurses, whoever we're dealing with, a roadmap to follow in specific situations.
Yep.
And this is very important for organizations because if we just take a step back and think for a moment, a lot of times patients, when they reach out to our different organizations, the first person they speak with could be a staff member that is practicing their particular skill in an organized call center staffing. So they become the front door. They often become the first person or the first experience a new customer or an established patient could have with our organization. So it's especially important from strictly a service perspective that we get it right the first time. We appear to everyone that we as an organization really know what we're doing.
Yep.
So I say that just in general. And then also we talked about, some of the dangers by not having documented workflows that are established, agreed upon, understood, taught, monitored, and enforced.
Mhm.
So we have talked about damage that can occur when those things don't happen. But I do want to, again, take another step back and think where we in our industry are coming from. And it can lead to a very dangerous situation if we don't have organized processes to follow. And I say that because we're in the business of healthcare. So the number one goal that we have in our efforts is access.
Yep.
Patients are calling us to access our institution. And access is a very popular term out there in healthcare and everywhere, but it means can they get from us what they need? So, to sort of take a broad look at what we do with workflows, knowing that we're committed to access, if we don't provide access that's successful to patients or potential patients, customers, when they call us, it can be very dangerous. And
Mm.
it can be very dangerous on three levels. It could delay care. So, someone having chest pain or numbness could possibly be experiencing symptoms of a heart attack or a stroke, which could lead to death. Okay. So, that's a very dangerous situation. If, oops, you're talking to the wrong person. Oops, we don't handle that. Oops, I'm going to put you on hold. We see a danger there. We also see a danger of limited access in the prevention of preventable disease, not getting an appointment with a provider in a timely manner. Say when someone starts to experience excessive thirst, excessive urination, which, skilled clinicians know could be a potential sign of diabetes. So we could be preventing care and delaying it for symptoms that could be mildly mannered rather than waiting time and having them be more serious. So, impeding access, delay care. And then, thirdly, we can be responsible for unavoidable deaths. Someone could die. We want to be sure that, from our perspective as a technology company, we are committed to access as are most technology companies. So, in that way, by not having workflows that work, it can be very dangerous to patients. And again, to the clinician's license for not providing prudent care, and to the organization as a possible litigious situation that could result in a high payout to the patient. So let's just establish that not having workflows can be dangerous. Now, let's take a step back, not be quite so drastic with the impact of workflows, and definitely not having workflows in place can be very consequential. And I say that because we're seeing in different clients or organizations that I deal with, especially larger call centers, for profit call centers, organizations that take on clients, we are seeing something called shared risks. Okay. Meaning, what I'm most familiar with is we saw a surge with Obamacare where organizations were penalized for unplanned readmissions after a patient was discharged from the hospital. We began to see great efforts in making sure that organizations that made post discharge callback communications to patients were doing this for organizations, just checking in 72 hours after discharge to make sure you're feeling okay, any new or different symptoms. Are you taking your medications as planned? So call centers and triage nurses were making these outbound calls to check on patients. Well, they were doing this, and organizations were paying outsourced call centers to do this because if they had certain patients who were admitted or readmitted on an unplanned basis within 30 days of discharge, the organizations were penalized. So, as an effort or to sort of head this off at the pass, organizations were investing the money to have call centers or their own triage nurses make these outbound calls and make sure everything was going okay. So, what we saw, different call centers, especially the for profit ones, were that organizations were contracting with them to make these post discharge callbacks, but they were saying to the triage nurses at this particular organization when they signed the contracts, okay, fine, any patient that is readmitted, even though your nurse makes the call to them and deems them okay, they don't need any further services, they don't need to be seen, and yet they still end up getting admitted. Well, we want to deduct 1% off of what we owe you for every patient that is readmitted that was under your care. So we began to refer to this as shared risks. Not only was the healthcare organization trying to manage the risk of readmissions unplanned, but they were involving their vendors in the responsibility for keeping these patients out of the hospital. So, in that way, if nurses and administrative staff were not managing these patients appropriately as soon as the phone rang or as soon as they reached out to these patients, well, then that would be a problem because it could cost both organizations money. So when it really starts to hit the bottom line, we tend to see definitely an enforcement of workarounds that could possibly be causing expense to the organization or decrease any savings that could be achieved by following designated workflows. So just a little more insight on just how important the workflows are.
Very good. Yeah. So the topic of workflows, it's a deep topic, right? The workflows are really complicated. And because we're dealing with patient access, you're you have to remember our agents need to be supported and our frontline nurses need to be supported just as much as the doctors do. There's a lot of, I think, understanding that the doctor's work is complicated, that they need to build a relationship with the patient, that relationship involves truly understanding the patient and serving them. And there's a lot that goes into properly charting, recording, billing. But all of that complication starts way before the doctor's talking to the patient.
If we think back to the clinic setting, okay, we do an awful lot for the patient prior to the doctor even stepping in the room. And
Mm,
again, we need to perform all of those clinical tasks, making sure, we're not going to put this patient in the room if we need to call 911 for them.
yep.
Same thing with the remote virtual call in encounter with the patient. We have prompts in our workflow, when a non-clinical scheduler or agent answers the phone, if a patient talks, I'm not feeling myself. I lost consciousness. I'm having chest pain. We have embedded within our very sophisticated, tuned in workflows that immediately take that patient from a non-clinical environment immediately to a nurse.
Right.
That's a vital component of our workflows. And again, we're not talking about United Airlines. We're not talking about Volkswagen. We're not talking about Verizon. We're talking about healthcare, which until we are able to do a little investigation and identify in a matter of seconds that this is not a life or death issue, there are specific steps we want these non clinical people to follow. And again, this is always done in collaboration with a clinician, just like in the office. The patient checks in at the front desk, but behind the doors are all the doctors, and we're set up the same way. You call, the non-clinical person answers the phone. It just like you step up to the front desk. What's your name? What's your date of birth? Can you verify your insurance? Do you have a copy of your insurance card? Okay, you're here to see Dr. Jones for what today? And then we switch to virtual. I'm having a sore throat. I've had it for 3 days. It's not getting any better and it hurts when I talk. Okay, great. So we move through those steps. Yes, okay, you are here to see Dr. Jones for your sore throat. In the real setting, in the virtual setting, okay, you have a sore throat. They immediately see a few prompts. They're speaking, they're not gasping for air. Okay, hold on 1 second. I'm going to get you over to the nurse. Stay on the line, and someone will be right with you. Translates to taking the patient back to a room, saying the nurse will be right in to get some information in your vitals, and walking out. So that time the patient sits in the room by themselves is the same time they sit in our queue waiting for the nurse to pick up the phone. So again, workflows are very important. And we talked about a minute ago how we are setting up the doctor to essentially be able to just walk in the room, hear what the patient has to say, and essentially really do just doctor duty. And so much of this essential stuff, these administrative tasks, do get performed by our non clinical partners. They're vital to us.
Mhm.
They take care of making sure that it's one of our patients, that they're up to date and current, that if we need to, we can get a hold of them. They verify phone numbers. Also, the work that's done with insurance. We have to be paid. Our organizations have to be paid. And there's very specific steps. There's boxes that have to be checked. There's questions that have to be answered. So it is essential that our non administrative people are able to function in an environment that contributes to their success, that everything is laid out for them that they have to do in the course of the call before turning it over to a nurse, that clicks all the boxes and makes sure that everything is performed and done. So then we move on to the next step of turning the patient over to the nurse. And she then has her own set of steps that are expected, that are part of the workflow. For nurses, we see the workflow mimicking the nursing process, which no matter what the specialty of nursing is, the workflow is always the nursing process. So we are very fortunate, the gold standard, the Schmidt and Thompson protocols, which we see nurses in about 95% of triage environments referring to and using to guide their practice. They have done the work for us. Schmidt and Thompson have based the architecture of their decision support tools on the nursing process. So again, we are providing the industry standard the standard of care workflow that is expected of nurses without them ever having to think about it. It's done. Don't skip any steps, and you will be following our workflow, and you will also be satisfying the standards of care expected of this particular specialty. So, workflow is important for every different person that the patient may encounter in their interaction with the organization. Operators have workflows, financial counselors have workflows, pre authorization people have workflows, x ray technicians have workflows. I mean, workflows are essential no matter what kind of job you're doing.
Mhm.
And it's very important for organizations to take the time to create workflows and commit to them, because in a way that's an organization's branding. This is how we do it. And when you do it well, that speaks to the organization. And when it's not done well, it's just like, oh my God, I can't even imagine what it would be like if I was there in person and had to experience the same level of frustration or uncertainty.
The workflows are important for representing your organization. They're important
Mhm.
for keeping the patient safe. They're important for not losing money.
Yeah.
They're important for maintaining standards of quality. And anyone who wants to offer something that is anywhere close to a best in class service needs something that patients and the staff can rely on
Mhm.
consistently to get the job done. So that's great. Even though we are talking about process here, which is a little different from technology and people, we can't totally divorce it from some of those other topics. So, what are some of the ways in which we have to keep in mind the people as we are keeping them in mind and involving them as we're working through our processes?
I can say when I consulted for a while, I worked with 30 different organizations trying to set up nurse triage or improving it. And the most dreadful experience was process mapping, because it was a very interactive exercise. And I'm going to refer to a piece of paper because I wrote down everything who has to be at the table. I
Mm,
mean, when we're doing process mapping, because let's think about process mapping for an organization. Let's say we're brought in and everything's a mess. All of our processes are band aided together. They were all reactionary processes. A problem arose and we solved it in real time as best we could, but we didn't involve the other people who we were turfing the work to. Or so process mapping with an organization as a consultant, when I did it, it was sort of identifying what the current state is and who's doing what. Okay. And the organization generally as a whole at a very high level declaring for us what they want the future state to be. So right now the patient calls and they may be put on hold 3 different times and transferred to 4 different people, but the organization in their lofty goal wants one call resolution. Whoever the patient is talking to, whoever picks up the phone, is the right person for the patient to talk to, because they will be able to resolve the issue for the patient. So that's the goal. But we have 100 different processes here that go down so many dead ends and detours. So we have to transform current state into future state. So we want to, first of all, make sure that all the stakeholders are at the table. And this can include our office staff, because remember, as call center people, we don't really own any patients. We take care of patients or do whatever we do for the clinic's patients, the hospital's patients. Their phones roll to us, their communication methods roll to us. But these are your patients. We're helping you out with them. So we want to make sure that we have all of you at the table so you understand what we get, what we do with them, and why, and how we think we can do it better. So we want those receptionists, the operators, the schedulers, the front desk people to be at the table. We want them to hear what's going on. We want to be sure, of course, that our providers are represented. And now we probably have just as many physician extenders, meaning physician assistants and nurse practitioners, if not more, than providers taking care of our patients. So we want these people at at the table. If our doctors and our high level providers don't know what's going on or they don't have a say, we're going to be sunk. We also want to make sure that our nurses are at the table. We all know that so many calls go from non clinical people to nurses. Well, are you right in sending it to the triage nurse? Or is this something that should go to the office? So we want the nurses at the table. We want the telephony team. We want to understand why the calls are routed to the people they're routed to. This may have been something that there was never any thought put into it, but we want those people at the table. We want to know, what are our IVRs doing? Why are nurses getting calls about quit smoking campaign or get a new car seat? So the IVR, the voice response system, that is one of the best ways to ensure that you are starting your workflow out appropriately. The calls are being routed to the appropriate, oftentimes non clinical people. And then we save that last little offering for a nurse till the end because we know that people will always pick the human being before anything else. So we want to start out this workflow involving our telephony people. What are our capabilities? Can we do this? How many messages can we have? How many phone lines do we have? So telephony is essential. And a lot of times in my experiences, Stephen, I've discovered that when people or organizations start to consider centralizing in contact center, office telephone mechanics or intricacies are very different from call center telephony matters, technology, machinery. So a lot of times the issues with telephony, people take it personally if it can be implied that maybe we need someone with a different skill set involved here to oversee the telephony for this big centralization push. So we want telephony there. We certainly want any representation of IT around the electronic medical record. You know, we want to make sure, ideally, in a perfect world, in a workflow dream, that when the phone rings, it automatically communicates with our electronic medical record and signals the patient that's calling and brings up their electronic medical record. So I'm a nurse, so this is not my area of expertise, but again, I know it's a possibility, but I need these two groups to communicate with each other to tell me, can we do this within our organization? So we want them to hear that this is what we want. Can you do this? And
Mhm.
also, Stephen, having all these players at the table, it allows everybody to hear the same thing at the same time. And if we can have this high level executive, our executive sponsor for this workflow design exercise, the one who endorsed it, be there at initial meeting just to have everyone hear that he or she is telling us we need this to be done. We need to do this for our patients. That is essential. We want everybody on the same page. And then we've also had different process mapping or workflow design sessions where we've involved compliance, legal, ethics, even marketing. We're going to develop this great nurse triage line or patient self scheduling software we're going to incorporate or offer. Well, you can't just build something and they will come. You have to build it and then dole it out to the patients. Offer a new nurse triage service line, but roll it out intelligently to practice after practice and have your marketing team send out mailers or hand out cell phones, those little things you hold with your number on the back or something. Be involved in advertising it and making it an attractive option so that we're not doing all this work for nothing and that it is actually being used as hoped for. So workflow is something ultimately that we want it for the patient. We want the patient to have a stress-free conversation, encounter, chat with our organization, plotting it out so that every contact with a human being or a task is impactful and getting them, if not the first time, getting them quickly to the appropriate either line, office, service to resolve their issue. So, yes, you're very correct that workflow affects everyone, but ultimately, everything we do in our industry, healthcare, is to benefit the patient and their health outcome.
Mhm. We've got doctors, nurses, the telephony experts, the HR experts, and marketing. Anyone else that we're missing?
Stephen, yes, actually, now that you say that, and I don't know, you can help me with this is your area, but like many times we would have business intelligence to be
Right.
part of it because remember, we're
Yeah.
there, or as a consultant, I was there because this high level
Yep.
executive signed the contract and was willing to pay for me. So business intelligence is usually connected to the highest levels.
Yep.
So if strategy, the CEO brings us in to centralize this call center and make it smooth, first call resolution is our goal.
Yep.
Well, then they're going to want evidence of the fact that we are resolving calls in one phone call or one encounter.
Mhm.
So they're going to be listening in for whatever they need to know or talk to telephony guys or the electronic medical people to understand what they're going to need to tap into or what data they're going to have to collect or how they're going to get it to determine that really and truly there's a first call resolution, it's been achieved, and our effort or our exercise is successful. So, and Stephen, when I say that, everyone is listening from their own specific mindset. Everyone is hearing things and processing things from their own perspective, what they know, and what's expected of them. Everybody thinks they're doing things the best way possible. Nobody can take on one more bit of work. I mean, all of these people in healthcare, Stephen, they're exhausted. They're fatigued. There's been so much change introduced, so much technology introduced. And it's up to these project managers or these consultants to continually reassure people, allay anxiety. And it's hard. It's the unknown until you actually go live and have 30, 60, 90, 180 days of
Mhm.
performance to really be able to reap the benefits of this great effort. It really is a thankless job for a very long time. And you often don't get thanks from the frontline people. Generally, you get your first thanks from your high level executive sponsors who are able to see the difference, you know, and then little by little they come around. Doctors see that they are, when we have a successful nurse triage line, we know that 50% of the time no further action is needed.
Mhm.
So doctors are not having their valuable slots filled with unnecessary appointments. And then they see patients that are in more need, more critical symptoms, more
Mhm.
chronic diseases, which in the long run have higher reimbursement rates. So doctors' numbers rise in
Mhm.
time. So we sort of see it trickle down the benefits a lot of times from the top down.
Mhm.
We see the most concrete benefits of what we're doing. Frontline people, they do notice the differences, but as we consolidate roles and functions, everything ends up getting busier, busier, busier. So things will always pop up that you couldn't have possibly thought about. People tend to focus on the negative things sometimes. We
Mhm.
see this a
Mhm.
lot of times with our frontline people. So you tend to get your best indicators of success at the highest level first,
Yeah.
trickles down to the providers. The CEO will communicate to the providers in internal medicine. You guys are great. Since we had patient self-scheduling and nurse triage and virtual visits all combined, those are the conclusions that we are looking for.
Yeah.
Those are meaningless to nurses. We rarely want to talk to nurses about money. They don't want to hear about it. The big bang
Yeah.
collision of nursing and business, it's out there, but still, we want to be sure if we possibly can to translate any revenue dollar conversations to nurses in the form of outcomes, healthy outcomes, saved a life, reassured a widow, the more empathetic
Right.
human things that nurses are able to convey to patients.
Too many people, when they're thinking about change and the need to implement, say, better processes, they wouldn't express it this way, but a lot of their expectations are it's going to be a magic pill and I need to see
Yeah,
something immediately. Or, and this was, I did all this effort for nothing, right? You need to know this isn't a magic pill and it's not going to be that way.
yeah.
It takes effort, time, and the feedback loop comes to this is one of the reasons why you involve all of the people that you were talking about, because the
Mhm,
feedback on the benefits is split out to all of those stakeholders, right? Each of them sees a different portion of the benefit. None of
mhm,
them is going to see the entire benefit. So you got to
mhm.
be patient and work with it and let the communication between the parties work itself out as you're implementing the new system.
This is something with nurse triage that has always really bothered me. And the other night I was on a call with the AAACN, American Ambulatory Care Nursing, and telephone triage sits under that umbrella.
Yep.
And we were talking about different things, quality, and it was a quality call. But what is really interesting to me with nurse triage is that all nurse triage is evaluated on is the process, is the workflow. Did you select the appropriate protocol? Did you identify the right symptom? Did you ask all the questions? Did you confirm the medication list? So it's all process. And unfortunately for triage nurses, a lot of times they don't know, oh, I was triaging this patient and the recommendation was a 24-hour, be seen by your physician within 24 hours. But something just wasn't right about how they sounded. So my recommendation is you need to be seen within the next 4 hours by a physician. It's 10 o'clock at night. Go to the emergency room. Well, nine times out of 10, triage nurses don't know. Were they right? Was
All right.
something going on?
Yeah.
So their ability to, yes, follow the workflow, use the decision support tools, but also intrinsically incorporate the
Mhm.
critical thinking skill, which ultimately contributed to using all those tools. What happened? Were they right? To me, that's a workflow, a nursing workflow that sort of stops rather abruptly. And it's interesting because we talk about like when you have all the players at the table, compliance. Well, when I was at Cleveland Clinic, our nurses, they triage so many patients and they'd have these situations where, something just wasn't right. I'm going to send this patient in just for an evaluation. They'd come to work their next shift and they would look the patient up. What happened?
Mhm.
Was I right? Oh my gosh, he was having a full blown heart attack. He was there just in time. That is very validating and it really contributes to triage nurses who really aren't touching, seeing, interacting in person with patients, a sense of value
Right.
and necessity.
Right.
Well, compliance came and told us, you know what? Your nurses have to stop going into the patient's charts because they're done with
Oh,
their part of the
right.
patient's care coordination.
Oh, yeah.
So they have no role in anymore. I understand what compliance is saying. I understood that, but then we sort of said, can we organize this a little bit? Can we give you a list of patients that perhaps were sent to the emergency room using nursing judgment and let us know what happens? Well, of
Right.
course, they were too busy to do that and it never happened. But
Yeah.
that's just an example of so much has gone into mapping out the workflow of what nurses do. But to
Yeah.
me, when you get right there, you kind of fall off the cliff.
Yeah, yeah. I mean, you gotta
Yeah.
realize this is healthcare, and we're in this for
Mhm.
people, not for the process itself, right? So the
Mhm.
process needs to facilitate the helping of people. It's hard sometimes, particularly when the feedback doesn't come to you. Back at the end of the day, goes to someone else, and then you're left kind of scratching your head. Keeping in mind the motivation for your employees is pretty important. We talked about how the buy-in to change can be kind of undermined because it takes time and it's a big lift and that feedback loop goes to a lot of people. So what are things that we can do to enhance our buy-in to change, particularly from those who aren't directly on the front lines of patient access. The clinical people, the nurses, the doctors, how can we help them buy in to get involved in this process?
First and foremost, I'm going to say the people that we are dealing with are employees of our organization. When you work for an organization in the past, mostly, not lately, the staffing shortage in so many industries is in crisis state. But in the past, you work for an organization. Here's our values, here's our mission statement, here's what we do, and that's what's expected of you. Now, especially in healthcare, with such a shortage of physicians, a shortage of nurses, a shortage of call center people, entry level people, there tends to be much more of an emphasis on everybody's input, everybody's thoughts, what everybody wants, how they want it done. I'm still going to go back to the old thinking
Mhm.
that we work for an organization. Our organization has very high standards. We have professionals at the top that have led successful organizations. And this is the decision that we've made and what we have to do as an organization to survive and remain solvent and keep you employed. I came from a very strong organization, Cleveland Clinic, and a lot of times there was the sensitivity factor that was communicated, but sometimes things just had to be done and you just had to have faith. So I'm going to say that from the very beginning as buy-in. You want to work for us? Here's what you do. I'm maybe a little old school saying that, but again, we get their buy-in, or some people just, hey, I work here, this is what I'm gonna do. I have 20 years and I'm not going to start somewhere else new, however it materializes. So we say that this is what our organization wants you to do. Not always the greatest thing, but a lot of times the bottom line. Next, I think to get buy-in is that everywhere we have gone from a fee for service to value-based care. Okay. Value-based care, it was essential. There were records of so many unnecessary tests being performed, billing for things that weren't done. Healthcare was one of the last industries where we are expected to look for a value in what we get.
Mhm.
Patients became consumers. So we have to look more at our bottom line, eliminate waste, okay, and function and satisfy the organization by being financially solvent, okay? So patients became consumers. Being consumers, we have the expectation for consumers that they're satisfied in either what they purchase or what they experience. So for us, customer satisfaction really jumped to front and center
Right.
when we started to centralize call centers, create contact centers, communication hubs, and maybe in the beginning, it started out pretty well. But as the value and the economic feasibility of centralization became clear, we began to have some bottlenecks and some activities that were occurring that were not very satisfying to our customers, the patients. We began to view them as consumers and we began to have to satisfy them. This is really where the big push and came for a lot of the technology that we've developed, but it also came from knowing we learned a lot from what patients told us. And one of the biggest things with technology is that we are able to sort of have omni-channel or one platform for everything.
Mhm.
All of the demographic information is right there. All of the clinical information is right there. All the tools the nurse needs to clinically care for this patient, coordinate their care is all right there. This became the great change for how we began to treat our patients as consumers. And also, we had a lot of fat and a lot of waste in healthcare. And it was through the call center that a lot of this was exposed.
Mhm.
Just centralizing Cleveland Clinic, we began to realize as an organization, they had 2,000 phone numbers. And just things like that. It was just one thing on top of another until it was just a mess. It just collapsed, an avalanche, everything just fell. And we had to start rebuilding from scratch. Again, we are forced as leaders to emphasize the importance of value based care. We're not going to be paid just for nothing. And then we saw bundled payments, and then we saw calls coming after hours from patients who were part of a bundled payment plan. And oh, we're only going to get $500 to care for this patient. So even if you triage them and it comes up they need to go to the emergency room, we're still going to put in this workflow that you've got to reach out to an on-call provider to make sure they want them to go to the emergency room,
Mhm.
because in this value-based situation, your incentive as a provider could be minimized, and it could either just be a percentage to keep people unnecessarily out of the emergency room, but it could be with a financial benefit and incentive too. So it's very important to sort of drill down how value based care impacts everyone and how everyone has a responsibility in providing it.
Patient first, value first,
Patient
patient
first.
satisfaction first,
Yeah.
right? It
Yeah.
impacts your reimbursement. It impacts whether patients come to you. It's not the same as it was 20 years ago.
Right. And then, Stephen, other ways to incentivize. I mean, in healthcare, I see over and over again, you can't motivate nurses with more money. Don't throw it off the table yet, you know. But
Yeah.
I do
You just
think
have a
that,
chorus of nurses disagreeing with that statement.
yeah, financial reimbursement is a big reimbursement. Nobody has enough time and money. Another thing to get buy-in, and we said this in the very beginning, having everybody at the table, having them at the table, hearing, hearing
Yeah,
what they
like
have to
that.
say,
Right,
understanding
right.
their fears, being a good project manager and maybe jotting down a note. And when you're in the process of the design or at some phase, if you can remember it, go back to it and say, we did incorporate your suggestions, or we're not going to have you guys have to do that. So it's really having them present and heard and let them be part of it. You're not doing the workflow design to them, you're doing the workflow design with them
Yeah,
for them.
that's right.
So as best you can communicate them, they will be along with you. And Stephen, this might seem a little old fashioned, but so much of what we do now is remote and virtual. But I say as much time as you can spend in the presence of people who workflow is going to be impacting, do it, because you tend to form a different bond with people
Yes.
when they know you or they look you in the eye.
I like that. So it's not just bring people to the table as you're walking through the workflows. Let them experience it too.
We didn't know who the nurses were in the offices. We never met anybody. Well, as part of our orientation plan, I started to have our nurses go to the clinics. I mean, they all knew they were nurses, but see what they're dealing with,
Yeah.
see what they have,
No.
and not so much that to see what they do or how they do it, but I want them to know you.
Mhm.
I want you to know who Betty is at the Solon Clinic so that when you're
Mhm.
having a problem, you have a resource, but you also are more empathetic when Betty didn't manage to, on a busy Friday afternoon, call in a prescription for a patient and you have to do it and it should have been done by the office. We always tried to get people to know who was who, even have nurses sit with the schedulers. It can't
Mhm.
always be you versus us. And that did tend to work out pretty well. And also, we wanted the nurses in the clinics to come and sit with one of our nurses and see what it's like on a Friday afternoon at 5 o'clock when we get 700 calls in a 15-minute span because everything is closing. And you understand the frustration we have when the office doesn't complete the tasks in the queue. Or there's 25 calls on hold that have been on hold for your office for 20 minutes, and then you roll them to us and they're back in another queue. Having relationships with the people that you're dealing with, it does contribute to buy-in. Again, as you start to roll out changes or design workflows, you can't go live with everybody's workflow changing on the same day. So a planned, titrated rollout is great. And if you like at Cleveland Clinic, when we first started centralizing, we did like one institute or one specialty. It started out every 6 months. So digestive disease went first. After that, women's health. And it really gave us a good amount of time to work out the kinks. And really, wow, we thought this would work out great, but for some reason, for this reason, it's not. So we would change it. The first week, everybody was ready to call. This isn't working, that isn't working. And it was just sort of, let us just work out some of the speed bumps here. So we were able to reach out to our executive sponsor and say, this is a big thing that we've been tasked to do. Could you please ask the group, or please say the access team is doing a great job, but we just need 30 days before we're going to allow them to make any changes to the bill. And so we were able to work kinks out. And then after 6 months, digestive disease had good statistics, good data, and good anecdotal stories from patients as well as caregivers to share. And that was great. So the physicians began to see tangible, proven, on paper, black and white benefits. So digestive disease was able to communicate that to women's health, who communicated that to neurology. So your success stories go a long way. Saying that, so do your horror stories. There are people that are just always going to emphasize the negative, but
Yeah.
again, highlight success stories if you have to. We sent people to different call centers. Our leadership went to Zappos, when we were first starting to look at call center stuff. And that was like magic. I remember nurse on call, I think in our original orientation manual, and as time went on, we probably had 10 different applications we had to sign on.
Right.
The on-call schedule, the medical administration record, the electronic medical record, the phone, so many things. And when a platform like ours came out, when OCAR first showed it to me, helped us, and I looked at it, and on one screen was everything. And you just toggling back here, there. Oh my God. To me, it truly was like magic. I couldn't believe it. It was like, it's unbelievable.
A bunch of the issues and changes and improvements that you talked about do raise the question about quality assurance for workflows and making sure that what you're delivering is, well, one, continuously improving, but two, going to be best in class. So how do you do that?
Well, the first thing that you do to make sure that it's a quality process workflow is that you respond to outliers and special situations right away. We can never think of every possible scenario for everything. So when things arise, respond to them in real time, do a deep dive, root cause analysis, whatever you want to call it. Incorporate your lean, whatever strategies or practices. You want to identify things right away, and you want to correct them. And we're not perfect. We didn't anticipate this or this change. So you want to do that. And the people that often pick up on this, a lot of times with your workflows, are your frontline people. Your schedulers are going to let you know right away what's wrong. And so you rely on that. You rely on your nurses. We're getting all of these, whether it's a specialty call or the provider, when we page him, he's not responding. You want to identify any problems with your workflow as soon as they come up and correct them. The way to do this, your frontline people alert you, your doctors alert you. Anywhere there's something that is not satisfactory, you want to address it immediately. It's done through listening to the calls to make sure that whatever the documentation is and the call is, you're monitoring them at the same time. You always want your verbal to match your written. Okay. So you want to make sure that that's working, and that's done through your quality monitoring. Now, there are also very sophisticated tools out there. I remember that there's products like NICE. I just remember from being in different call centers where they can just listen to calls and flag words and make sure that nurses are verifying understanding in every call. So we were able to listen to calls and just listen for the word understand. So that was a very sophisticated technological way to monitor, verify understanding. We want to make sure that if you can do that, what does that indicate? What can it indicate for what you are expecting people to do? And Stephen, we want to make sure that we are monitoring what we have trained the employee to do.
Exactly.
And I've said this before, the easiest way for organizations to do this, in my opinion, always was. And this was only came about after we had so many nurses and it was so hard. And I want to make sure that my job description describes what's expected, job expectations. We expect that you speak to patients in a courteous and empathetic manner. So I'm listening for tone of voice, follow established processes, use critical thinking. Then we're saying that in the job description. I want to be sure that I'm teaching people how to speak in a courteous manner, active listening, how to talk to hard of hearing people, using translator services. So I'm teaching that so that when I'm monitoring my calls and I can say, you're talking too fast and the patient is not able to understand what you're saying. So consequently, everything you say, they're asking you to repeat. So your call time is double. You need to slow down, speak in a thoughtful manner, and I can pull training pearls of wisdom from my orientation packet and insert it in the call review as a reminder as to this is how you have to do it. So monitoring quality, it can involve many different tools. I'm going back all the way to how it was done manually. You
Yep.
actually listened and compared the notes and made sure they matched. It's very interesting. I was on a call, I said the other night, with a bunch of nurses. There were 35 nurses on the call. And quality, I think, is an extremely neglected responsibility of every organization. I spoke with nurses, one of the nurses from one of the 3 top health systems rated year after year in the United States. They're triage nurses. They monitor 5 calls a year. What nurses shared about quality, it was really amazing to me. And just the fact that quality is, I will say, neglected in
Mm.
that the environment for nurses and having enough nurses, it is so fragile and brittle right now. I'm sensing that nurse managers are afraid to look at a nurse the wrong way, that she might walk out the door. And so when we were discussing quality, it was, in my opinion, it was not a robust enough exercise.
Yeah.
There were organizations that reported monitoring quality but not scoring. Well, okay, to me, that why are you wasting your
Exactly.
auditor's time? So quality, I always go back to what Dr. Cosgrove, the CEO of Cleveland Clinic when I worked there, said: if you're not monitoring it, you cannot improve it. We're lifelong learners. We
Hmm.
always want to do better. Don't you want to make sure you're doing the very best job for your patient? You have to
That's
spend
right.
a lot of times anything unpleasant, the money aspect of nursing, spin it.
Hmm.
We don't care about the money, we care about the patient outcome. It's not about finding something wrong with it. We want to make sure that you have what you need to do your job. We are doing our patients a disservice by
How
not
can you be a
making sure.
best in class world organization if you are not reviewing and giving feedback constantly?
Average handle times, they vary, but let's say the average is 4 per hour. That's 32 calls a day. Okay,
Yep.
times 5, that's 600 calls a month.
Hmm.
That's 7,200 calls a year, and you're monitoring 5. Lots of nurses don't really even think of things this way, but state boards of nursing, okay? The board of nursing is not there to protect nurses. The board of nursing is there
Right.
to protect patients
That's right.
from nurses
Yep.
who may have issues with their practice.
That's
And
right.
believe me, I'm 100% pro nursing,
Oh,
but
yeah.
I also see that we have to make sure that our patients are safe.
You're protective of nursing, but you're proud of nursing. You're proud of what nurses can do. You're proud of what nurses can be and how they can help patients, right? And so part of that is like stepping up to what true quality really is and what nurses really could be, not
Right,
just, grabbing the nursing title and then sloughing it
right.
off, right?
And
That's
Stephen, you know what? I mean, nursing school, sure, nursing school, did it, you take the boards, whatever. What I learned about nursing came from doing it, but also from the
right.
nurses who came before me. who coached me,
Mhm,
who helped me.
mhm.
I had one nurse, and she was a good, wonderful nurse leader. Oh my God, the swear words that she used to say and call me. But it was like she had my back. She wanted me to be the
Right.
best,
Yeah.
and this was like sort of when I was starting to assume more management responsibility. And I remember one time we were walking out of the meeting back to our office, and she's like, "You look like an idiot. You look like an idiot," and it was just like, but I will never forget it. She was right.
Right.
She never said anything that wasn't true and didn't help me. So when we're not evaluating our nurses and sharing expertise from subject matter experts or peers that have come ahead of us or have handled a million calls in their career, we're doing our nurses a disservice. I
Yeah.
just thought that information about quality monitoring, it was very interesting to me. It was
Yeah.
scary. But here were all of these nurses, nurse managers really being so candid, and they can't afford to lose anybody. So,
Well, that's what they think. That's the problem, though. I
yeah,
mean,
that's what
sometimes
they think.
you have to,
Right.
sometimes you have to.
Attrition is more important than recruitment now. Keeping
Yeah.
who you have, what do you have to do to keep them happy? And statistics came out that for every travel nurse an organization hires in a year, it's $1 million investment. Now, I don't know any nurse who's
Huge.
making
No,
anywhere near $1
no,
million.
no.
So to
Yeah.
keep these nurses and cut back on the
Yeah.
travel, we look at the whole big picture. The travel nurses are walking away from a job somewhere
Yep.
to travel and seize the opportunity. So that leaves a hole in that first place. So either they're having to hire a traveler or they have an open
Mhm.
position. So it's all interesting.
Thank you so much, Gina. This has been a wonderful conversation. And for those who are interested in more, not just about process, but also about evaluating people and technology, go to our website, keonahealth.com, and go to learning resources. It's our mission to improve patient access for everyone and for the world, not just for our customers. And you're going to find a wealth of resources there, from everything from nurse triage to scheduling to online marketing, as well as a bunch of the topics that we dived into today. Hope you do. And thanks again, Gina. We will see you next time.
Thank you, Stephen.